Hello students, welcome to Distinction Learning Platform, and on this platform you'll find explanation to difficult topics, you find revisions, you find tests, quizzes, a lot of stuff. So before we begin our lessons, make sure that you subscribe so that you can be updated with all upcoming videos. To make the story short, let us begin. In this video, we're talking about cholinergic agonists and receptors, and also the clinical uses of cholinergic agonists. So this is under pharmacology series. Okay. So we talk about cholinergic agonists, or the other term that they use is what we call parasympathomimetic. So that's the other term that they use. Okay. So talk about everything about that. The major function of the parasympathetic nervous system. Okay. We'll talk about the direct agonist. We'll talk about indirect agonist clinical uses as well. Okay. So what is a parasympathetic nervous system? So parasympathetic nervous system basically is a type of system that likes what? So that works best when someone is resting and also when someone is what? Digesting. So it promotes digestion and also what? Resting. Okay. So in simpler terms, how can we summarize that? Okay. How can we summarize that? By using this what? Simple mnemonic. Because if you know the function of what? Parasympathetic nervous system, basically it will also tell you the what? The clinical uses of that, and as well as what? The side effect of the drugs that we are going to talk about. Okay. So I've got this mnemonic, which is a sludge beach pig. So this mnemonic, it summarizes all the functions of what? Parasympathetic nervous system, and we are going to pick at least one or maybe three functions that we use clinically. Okay. So what's the first one? The first one is what? Salivation. So the first one is what? Salivation. Okay. The first one is stand for what? Salivation. Basically, the parasympathetic nervous system promote what? Salivation. What else? L stand for what? Lacrimation. Okay. Then U stand for urination. Okay. D stand for defecation. Okay. Then another D. Another D stand for what? Digestion. Basically, it's promote what? GI secretion and what? GI motility. That is for D. It is digestion. Okay. Digestion. Then B stand for what? This one. B stand for bronchoconstriction. 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 Constriction. Okay. E stand for what? E stand for which is eye accommodation. Accommodation. Basically, if we talk about the eye accommodation, we're talking about the near type vision. So it's promote what? Near vision. Okay. So that's about E. It is eye accommodation. What about another E? Another E is talks about what? Erection. Okay. Erection. Okay. So that parasympathetic nervous system promote what? Erection. Then ejaculation that is provided by what? Sympathetic nervous system. Okay. Then what about another C? Another C is what? Constriction. Not bronchoconstriction, but this one is what? Pupillary constriction. So this is what? Constriction. Okay. The other H, that is for what? Like heart rate. Okay. But basically, if you talk about heart rate, this one is going to decrease what? Heart rate. If you talk about the parasympathetic nervous system, okay, or cholinergic system. Then the other P, which is for pig, we're talking about pancreatic secretion. So it promotes secretion of what? From the pancreas, like promoting those enzymes for digestion, pancreatic amylase, trypsin, lipase, those enzymes that are going to be released because of what? Parasympathetic nervous system, by the what? Vagus nerve. Okay, pancreatic secretions. Okay. Okay. Then I also is going to release the certain important hormone called insulin. Insulin go to the liver and helps in the what? Remember, uptake of glucose into the liver cells and promote the other what function like maybe glycogen synthesis. Okay. So that's about insulin. Then what else? G stand for what? Basically the one that I'm talking about, promote what? Glycogen what? Synthesis. Okay. So this is the basically the summary of what? The functions of parasympathetic nervous system. You need to know that. Okay. Yeah. So now if you talk about that, now there is also an important concept that you need to understand. Okay. So this parasympathetic nervous system, if we talk about where it comes from, okay, from the CNS, so it has a certain flow which we call craniosacral outflow, okay. So craniosacral outflow, that's where you can see all these like cranial nerves, where they come from. So they promote this, they come from what? Craniosacral outflow. But there is a certain what? There's a certain exception. Okay, if we talk about sweating, although I haven't written here sweating, so there's also another important function, which is what? Sweating. Okay, sweating. Sweating is also promoted by what? Parasympathetic nervous system. But those the nerves that promote sweating, they're under T1 and they're under what? Sympathetic nervous system, but that's an exception. But how do you know? How do you know that this nerve is under what? Sympathetic or parasympathetic? It's because of what? The postganglionic what fibers, what they release, the type of what neurotransmitter they release. Okay. So what am I saying? Okay. So what I mean is this. So if this is the central nervous system, okay, this is the central nervous system, then you have a fiber that is coming from the central nervous system, then there's a ganglion, then this is the post-ganglionic fiber. So this one is a pre-ganglionic fiber, and this is what? A post-ganglionic fiber. Okay, and this is what? A certain tissue which is there. Okay, so for you to say that this is what? A parasympathetic nervous system fiber, you look at what? A type of neurotransmitter that's going to be released on the post-ganglionic fibers. So here, if this is sympathetic, parasympathetic, it's going to release acetylcholine on the what? Postganglion, there are postganglionic fibers there. Okay, there on the synapse, it's going to release what? It's going to release acetylcholine, and if it is releasing acetylcholine, then you are going to consider as one of the what? Parasympathetic what? Fibers. Now for sympathetic fibers here, they are going to release other what? Neurotransmitters apart from what? Acetylcholine. Then that is what? That is norepinephrine and epinephrine. Then they will be considered as what? Under sympathetic what? Nerve fibers. Okay, that is basically an introduction. Okay, for that. So, but basically, for sweating is under what? Although it's under anatomically, it's under what? Sympathetic nervous system. Okay, but if you talk about sweating on the postganglionic fibers, it releases what? Acetylcholine. One is considered as under what? Parasympathetic nervous system. Okay, you need to know that. Now, since you've understood about the parasympathetic nervous system introduction, okay, we need to understand something. Okay, now there are some important receptors that we need to talk about, because everything, if acetylcholine is going to be released, it's going to be released and act on what? Certain receptors, or cholinergic what? Receptors, because we're talking about also receptors. So we need to know the main types of receptors that about what? Cholinergic system. How many receptors do we have? We have about 5. Okay, there's M1, muscarinic receptor type 1, muscarinic receptor type 2, 3, 4, 5. Okay, so and the other important thing is we need to know these type of receptors, because these receptors or muscarinic receptors are what we call G-coupled protein receptors. Very important to take note that. But there is also another one which is nicotinic receptor, which is not a what? G-coupled protein receptor. Okay, so what are we saying? So M1, if this is a G protein coupled receptor here, if this is a G protein coupled receptor, and this is what M1 is a GQ, okay? So this one is a what we call GQ. Don't worry, we'll talk about it. What happens when M1 receptors are what? Stimulated. These are GQ type of receptors. And where can you find them? You can find them in the what? Let me use the blue marker. Where can you find them? You can find them in the what? CNS and also the stomach, particularly in the what? Parietal what? Cells. So let me just say P cells. Okay. These are the ones that helps to secrete what? Hydrochloric acid. So CNS and what? Stomach. That's why you can find what? The M1 receptors, which are GQ. Okay. Next. What about this one? If this is GQ, then this one will be what? G inhibitory. Okay. Where can you find the G inhibitory? Basically, this one is simple. You can find it on the what? On the heart. Okay. That's why you can find it GI. Okay. So that is G inhibitor. You can find it on the heart. It's the one that's going to decrease what? Heart rate. One of this is also important. What else apart from that? So if this is GQ, GI, then this is also GQ. Okay, don't get confused. So GQ now, the M3 is the one that you can find it like almost everywhere. It's everywhere apart from the CNS. Okay, so you can find it on the like lymph glands. You can find it on the salivary gland. You can find them. You find it on the what? Eyes, like on the ciliary muscles there, so that the accommodation can happen, because pupillary constriction can happen. You can find it like almost everywhere. Smooth muscles, so we can say like eyes. Okay, you can find it on the salivary glands, a lot of places. Smooth muscles, a lot of places. Okay, it's distributed. Then what about M4? Okay. If this is G2, then M4 will be what? GI. Very simple. GI. Okay. This is GI. So where can you find it now? This one, where you can find it is very simple. You can find it in the what? CNS. Okay. CNS. What about this one? If this is GI, then this will be GQ. Then you can also find it in the what? NS. Very simple to identify the location of what? Those type of what? Receptors. Okay, so now since we've understood that, now let's talk about on how a certain neurotransmitter that we talked about. What is that neurotransmitter that we talked about under parasympathetic nervous system? We said acetylcholine. Okay, so now from here, since we've understood the function, now let's talk about how acetylcholine is going to be what? Synthesized. Why? Because there are some drugs that are going to be utilized to make sure that the production of acetylcholine is not there. So we need to know the production of what? Acetylcholine, which is very simple. Okay, so now let's look at this one. So this is the axonal terminal. Okay, this is the axonal terminal, and these are different what? Cells that we talk about with different what? Receptors. Basically, if you look at here, there are how many receptors are here? There are what? There are basically 2, but including nicotinic receptors, which I'll talk about here. Nicotinic receptors are what? Ligand-gated ion channel type of what? Receptors, and they are very fast receptors. Okay, we'll talk about that. Okay, so now let's start with the production of what? Or synthesis of acetylcholine. How is acetylcholine going to be what? Synthesized? So remember that we're going to get what? The famous one. So we're going to get the choline. So acetylcholine is going to be what? Acetylcholine. First of all, choline is the one that's going to be gotten from what? Diet. Okay. So we're going to get choline. Choline, basically, you get it from diet, then it goes to the brain there, to the neurons, then it's going to be uptake into what? The axonal terminal. Oh, okay. Then if it is uptaken into the axonal terminal like that, by this transporter, what do we call this transporter? This is sodium dependent choline pump, type of a pump. So it's a type of sodium transporter. If choline enters, also sodium is going to enter like that. Okay, so that's a sodium dependent type of pump. Okay, so this one is going to make sure that choline is what? Inside. Choline is what? Inside. So let's just say CH. This is choline. Okay, choline is inside on this what pump. Okay, sodium pump. So let's just say this is a sodium what pump. Okay, so this sodium pump, this is what we call this is a very, very important pump because it's a rate limiting what reaction, because minus choline is going into the axonal terminal here, then there will be what no production of what of acetylcholine. So very, very important. You need to take note of what of that. Okay, now since we know that one, now there's a drug that's going to what inhibit this sodium pump so that we don't have choline inside in the axonal terminal. What do we call that? We call it what? So there's a drug that's going to inhibit it, that's going to inhibit this pump. Okay, what do we call that drug? We call it hemicolinum. Hemicolinum. Okay, hemicolinum is a drug that's going to inhibit that uptake transporter that depend on sodium. And if you inhibit that one, you're not going to have choline inside the axonal terminal. Okay, what else is going to happen? Also, if you remember, in the axonal terminal here, there is a what? A mitochondria. A mitochondria is very, very important to synthesize what? To synthesize what? Acetate, okay, or acetylacetate. Okay. So this acetylacetate is the one that's going to be produced by the what? Mitochondria here. So let me put the mitochondria above here. Okay. So this mitochondria is going to produce what? Acetylacetate. Okay. So acetylacetate. So this acetylacetate is going to combine with what? A choline. So this acetylacetate is going to combine with what? A choline. Okay. To produce something which we call acetylcholine. So acetylcholine, I will use ACH. So this one is going to produce what? Acetylcholine. Okay. So if you combine acetylacetate and the choline that is coming from the diet, then you're going to have what? Acetylcholine. But there is an enzyme that's going to promote this conversion. What do we call that enzyme? We call it what? We call it choline acetyltransferase. So choline acetyltransferase. So let me put it here. Okay. So what enzyme is going to what? Combine acetylacetate with what? Choline. We call it what? Choline acetyltransferase. Okay. Choline acetyltransferase. The one that's going to make sure that combines acetylacetate combines with what? Choline to form what? Choline acetylcholine. Okay. Now this acetylcholine is going to be what? Put into what? This acetylcholine that has been what? Synthesized, going to be put into the what? The vesicle inside here. Okay. Okay. So it's going to be what? Put into what? The vesicle inside there. So and this if it is added there, okay, there's a transporter which we call acetylcholine transporter. It's the one that's going to make sure that this now acetylcholine inside the vesicle is going to be transported into on the what? Axonal, near the axonal what? Terminal. So what am I saying? This acetylcholine, there is also a transporter that will help that newly synthesized acetylcholine to be stored and also transported. What do we call that? That is just basically acetylcholine what? Transporter. Okay. So what am I saying? So this transporter, so for it to come here or near axonal terminal, there is what we call acetylcholine what? Transporter. Again, there's a drug that's going to inhibit this what? Acetylcholine transporter. Okay. What do we call that? We call it what? Vesamico. Okay. We call it what? Vesamico. Okay. Vesamico. Okay. Vesamico is a drug that's going to inhibit acetylcholine transporter. Okay. If you inhibit that again, you're going to what? To decrease production or to inhibit production of what? Acetylcholine. Okay. Now, what's the next step that's going to happen? What's the next step? Okay. After acetylcholine has been synthesized, now basically the only thing that is left is what? This acetylcholine to combine with what? The axonal terminal membrane. If what? If something happens, if the action potential comes like that, because maybe for some reason the neuron has been what activated, then on the axonal terminal also the action potential reaches there. Remember, what's going to happen if the action potential reaches there? The calcium gated channels, what they are going to open, and the calcium is going to rush into the what axonal terminal, so that now this acetylcholine in the vesicle is going to be released on the what synaptic gap. Okay, so if this action potential comes like that, what's going to happen? Okay, calcium will start rushing into the what? Into the cell like that. Calcium will start rushing into the what? Into the cell, causing this acetylcholine to fuse with what? This axonal terminal, so that now this acetylcholine can be released here. Yeah, so it's due to action potential that will make sure that acetylcholine is what produced on the what axonal from the axonal terminal onto the what synaptic gap. Again, there's a drug that's going to what inhibit the release of what acetylcholine from the what axonal, or from the vesicles onto the what the axonal, I mean on the synaptic gap. What do we call that drug? We call it what? Botulinum. Okay, botulinum. Botulinum. Okay, botulinum is a drug that's going to inhibit the release of what acetylcholine from its what vesicles. So that's to summarize what we've talked about here is that, okay, the first thing that's going to happen is that choline is going to be uptaken into the what? Into the axonal terminal by the sodium pumps. Okay, sodium dependent pumps. If they are taken in, if the choline is inside there, what's going to happen to choline is going to combine with what? Acetate that is produced from the what? Mitochondria. Then this acetate and choline is going to combine to form what? Acetylcholine by the use of a certain enzyme called choline acetyltransferase. Okay, so but there's no drug that's going to inhibit choline acetyltransferase. It's not been shown yet. Okay, then if that happens, again, this acetylcholine that has been newly synthesized is going to be what? It's going to be put into the what? Vesicles and transported to the what? Axonal terminal by what? Acetylcholine transporter. Okay, acetylcholine transporter now is going to be inhibited by this drug, which is vesamico. Okay, if you don't want the further release of acetylcholine. Now if the acetylcholine is here on the axonal terminal, what's going to happen? If somehow maybe the neuron has been what activated, the action potential reaches the axonal terminal, the calcium gated channels, they are going to what? Open up, then calcium will start rushing into the axonal terminal, causing the what? Those vesicles to start releasing, or causing those vesicles to fuse with the axonal terminal and release what? Acetylcholine on the what? Vesicles. But there is also a drug that's going to inhibit the release of what? Acetylcholine on the what? Axonal terminal. What do we call that? Botulinum. Okay, so there are three important drugs that are going to be utilized when it comes to inhibition of what? Acetylcholine, acetylcholine on the synaptic gap. So the first one is what? We say the first one is what? Hemicholinium. The second one is what? Vesamico. And the third one is what? Botulinum. Make sure that you take note of that. Okay. Now, if that happens, what else now? So here now we have acetylcholine on the what? Axonal terminal. This acetylcholine, which has been produced, is going to act on three important what? Cells. There's this cell, and there's what? This cell. Okay. And these cells, they've got what? Different receptors. There's the first one which has what? Ligand ion gated what? Channel type of receptors. There's these two. This one is what? G protein coupled receptors, and also this one is what? A G protein coupled receptor. Remember that a G protein coupled receptor is a 7 transmembrane type of what? Receptor. So we'll talk about that. Okay. So now, since we've understood, let's start with this one. If this acetylcholine comes like that, it's on the synaptic gap, it will come like that. Okay. This acetylcholine will bind here, will bind on the ligand there. Okay, if it binds there, basically initially this channel was initially what? Closed. The moment acetylcholine is bind there, it's going to what? To open like that. If it opens, what's going to happen? Sodium okay, sodium will start rushing into what? This cell. Sodium will start rushing into the cell, and basically if sodium rushes into the cell, potassium will leave the cell. Then what's going to happen? Then what's going to happen is what? If this is a muscle cell, so basically this is a muscle cell. Okay, this is a muscle cell. Basically that's a skeletal muscle. Okay, and it will lead to what? Muscle what? Contraction. So what type of receptor where the acetylcholine binds here and it is ion gated, something like that. So it is an ion gated what? Channel. We call it what? Nicotinic what? Receptor. So these receptors are what we call nicotinic what? Receptors. Okay. These nicotinic receptors, these are the ones that can be found on the what? Skeletal muscles, and these are the ones, if they are activated by acetylcholine, they are going to cause what? Muscle contraction. You need to take note of that because we talk about myasthenia gravis, one of the clinical disease that's going to what? Affect the muscle contraction. Okay. So basically that's the first thing I think that's going to happen. Now let's go to this one. Okay. What about this acetylcholine? Again, if it's maybe it's not bound on the skeletal muscle, what if it's bound just basically on the other smooth muscle? Okay, let's pick the GQ. So if what about this one? If this receptor is what? Is a GQ. So if this receptor is what? GQ. Okay, what's going to happen? Okay, this acetylcholine will come and bind here. Okay, this is acetylcholine binding here. Remember that a GQ is a 7 transmembrane type of receptor. It has what? It has the intramembrane what? Protein, which is what? A G protein. So this is a G protein inside there. So if this is activated, remember that G protein has what? Has 3 types of subunit. It has alpha subunit, gamma subunit, and what? Beta subunit. Okay. If now acetylcholine binds here on the GQ, okay, so if it's bind there, the beta and gamma subunit, they are going to what? Separate from what? Alpha subunit. So what you're going to have is what? Alpha subunit. Okay, alpha subunit is the one that's going to be what? There. Okay, this alpha subunit is going to bind what? GTP, and release what? GDP. Make sure that you understand that. Okay, it's going to bind GTP and release what? GTP. Okay, then this alpha subunit will go where? On the cell membrane there and activate this what? Certain enzyme. What we call that enzyme? We call it what? Phospholipase what? We call it phospholipase C. Very, very important what? Concept to take note. Okay, now this phospholipase C, what does it do again? So this phospholipase C, it will go to the what? It will start breaking down the what? The cell membrane of this cell. Okay, and in the cell membrane of this cell, there is what? A certain what? Molecule which we call PIP2. Okay, phosphorinositol biphosphate. Okay, PIP. Okay, let's just call it PIP2. Okay, PIP2. So on the cell membrane there is what? PIP2. This phospholipase C is going to start converting what? PIP into what? 2 important what? Substances. What are those substances? Okay, the first one is what we call DAG. Okay, diacylglycerol. Okay, and the second one is what? We call it what? IP3. Okay, IP3, which is the inositol triphosphate. Okay, so now DAG is going to do something. So DAG is very important in doing what? Something. What does it do? Okay, it's going to activate what? Protein kinase what? Protein kinase C, and protein kinase C is going to start what? Phosphorylating what? Different target proteins, so that now there will be what? There will be activation of what? Maybe there's some channels on the what? On that cells, or maybe it's promoting vasodilatation. A lot of what? Effect that's going to happen after phosphorylation here. Okay, what about IP3? So IP3 will go to the sarcoplasmic reticulum. So we'll go to the sarcoplasmic reticulum and increase what? Intracellular what? Calcium ions. Intracellular calcium ions is going to also activate the what? The cell, like that. Okay, it's going to activate the cell. So that is the main important what? Action that you need to do to know about what? The GQ type of what? Pathway. Okay, so this is it. Okay, Then what about this one? This one, let's say this is a what? GI. Okay, if this is a GQ, now let's talk about the GI. Okay, although there is a G stimulatory protein. Now, since we are talking about cholinergic agonists, we just talk about the GQ and the GI. Okay, and also the nicotinic type of receptors. So now again, this acetylcholine, the same acetylcholine comes here. Okay, bind there. Remember that again, the same thing that will happen. This is a G protein. Okay. It's a G protein. This G protein, it has what? Alpha subunit. So alpha subunit that has bind to GTP will go to what? Will go to this what? Enzyme and activate this enzyme. But this enzyme is not phospholipase C, but it is something. Oh my god. Okay? So this this enzyme is not phospholipase C, but it is what? Adenylate cyclase. So this is adenylate what? Cyclase. So this is adenylate cyclase. This alpha subunit, okay? Will activate the adenylate cyclase. Okay, this is a normal thing that happens. Okay, so it's going to activate adenylate cyclase, and adenylate cyclase, what does it do? It's going to get what? It's going to get something. It's going to get ATP. It's going to get ATP and convert it into what? CAMP. Okay, cyclic AMP. This cyclic AMP now will start doing something. Okay, it's going to activate what? Protein kinase what? A. Protein kinase A, what does it do? It's going to what? It's going to start phosphorylating what? Certain what target what? Proteins, thereby activating the what? The cell. So this is the best what? Simple thing that happens biochemical using biochemical means. Okay. Now if this is a what? Gene inhibitory, this whole thing is going to be what? Inhibited. Okay, you are not going to have what? You are going to inhibit ATP CAMP production. You are going to decrease CAMP production. You are going to deactivate protein kinase A, and we are not going to have what? Phosphorylation for targeted protein. Basically, in the normal thing is, if you activate the G inhibitor protein, it's going to inhibit everything here and leading to what? The activation of what? This cell. Very, very important to take note. Okay. If you remember the location of these nicotinic receptors, where can you find them? There are two types of nicotinic receptors. You can find them on the what? On the neuromuscular junction. Okay, between the muscles and the skeletal muscles and what? And the neurons. You can find them, and where you can find them in the ganglia. Okay, those ganglionic on the ganglia from the preganglionic what? Neurons there. Okay, then as well as the GQ, we've talked about where you can find the GQ as well. Okay, and the GI, where you can find them. Now, since we've understood about this, now what else are we supposed to talk about? Now let's talk about now the direct agonist and what? The indirect agonist. Okay, so before we go any further here, we need to talk about what about this one. I haven't talked about this one. So what about this one? So this one, remember that acetylcholine is acting on this cell, and this cell. But what about what happens to acetylcholine if its work is done? What's going to happen to that? It has to be what? Destroyed by what? This enzyme. What do we call this enzyme? This is a very, very important enzyme because the one that's going to be what? Inhibited by indirect agonist. So let's know about this one. So what is this enzyme? This enzyme is what we call acetylcholine. Okay, we call it what? Acetylcholine. Okay, esterase. Okay, we call it acetylcholine esterase. Very, very important because if the work of this word acetylcholine is done, it will be destroyed by what? By this acetylcholine what? Esterase into what? Choline plus what? Acetate. Okay, it will be destroyed into that. Okay, so that choline can be what? Reused, like in the same way as it was used in the initial what? Step. Okay, so that's what happens. So we'll talk about the acetylcholine esterase, the one that's going to break down called acetylcholine, because it is its work is done on the what? On the target what? Cells. We'll talk about that. Okay, so now let's talk about the direct agonist and what? Indirect what? Agonist. So let's talk about that. So direct agonist, what does it mean? Say direct agonist. So direct agonists, these are the type of what drug that we give. so that they just direct act on what receptors. If a drug acts direct onto the receptor, then that is what a direct agonist. Indirect agonists, they don't act direct on the receptors, but what do they act? They act from somewhere else. Where, like here, they're going to act on this what enzyme. If they act on this enzyme, they are not acting on the receptor. It is what indirect agonist. Now, what are those direct agonists? What are those good examples of direct agonists that can be used clinically? What are those? The first one is what? So let's talk about the pirocampine. Okay, the first one is what? Pirocampine. This is the first direct agonist. Okay, what is the second one? The second one is what? The second one is the bethanical. Okay, the second one is what? Bethanical. Okay, bethanical. The second one is what? Bethanical. The other one is what? Methacholine. Methacholine. Okay, methacholine. What is the other one? So the other one is what? The other one is what? Carbaco. Carbaco. Okay. The other one is what? Carbaco. Okay. So there is pirocampine, bethanical, methacholine, and what? Carbaco. These are very, very important what? Important drugs that you need to understand. Okay. Then let's go to indirect agonists. So indirect agonists, as you see, we've got a lot of them. So the first one is what? Hydrophonium. What is the first one? The first one is what? Hydrophonium. Okay. The first one is what? Hydrophonium. What is the second one? The second one is now, let's talk about neostigmine. Very important one. Neostigmine. Okay. So the first one is what? The second one is the neostigmine. Okay. What is the other one? The other one is what? Physiostigmine. Physiostigmine. Okay. Physiostigmine. What is the other one? Another one. These are a lot. There is also what we call pyridostigmine. Okay, this is pyridostigmine. Okay, what is the other one as well? Apart from the pyridostigmine, there is also another one which we call rivastigmine. Okay, what is also another one? There is also another one which we call daneprazil. Okay, this is all daneprazil. So this is a daneprazil. Okay. What is the other one? The other one now, it's a very, very important one. Okay. Let's talk about this one. Okay. Galantamine. Okay. Galantamine. Okay. What is the other one? Eco sulfate. There are a lot. Eco sulfate. Okay. Let's talk about another one. Malathion. Okay. There is also parathion. Okay, parathion. These are the basic pesticide that we talk about. Okay, parathion, malathion, ecosulfate, galantamine, daneprazil, rivastigmine, pyridostigmine, physiostigmine, neostigmine, and what? Hydrophonium. Very, very important what? Things to take note. These are indirect. They are a lot. Okay. So now, since we've talked about where, so direct agonists, they go there direct on the what and on these type of receptors. Okay, they go direct on these type of receptors. Okay, but indirect, what do they go? Sometimes, so the indirect ones, they can either basically, so there are some that have got mixed function. So there are others that can just inhibit this acetylcholinesterase and the act on the what? Neuromuscular junction, like what? Neostigmine. So we'll talk about the neostigmine because it has both function. It can inactivate this one, okay? And I mean, so indirect, basically, so what I mean is indirect, they just act on what acetylcholine esterase. So we talk about the clinical features. Don't worry, I don't want you to get confused. Okay, so but basically these are examples. Okay, so now let's talk about the clinical features of what clinical features of cholinergic agonists or parasympathomimetics. Okay, so let's start with the first one. So what is the first one? So the first one is what? Clinical usage. So the first one is what? Myasthenia gravis. So what is myasthenia gravis? So myasthenia gravis is basically an autoimmune what? Autoimmune disorder or disease where autoantibodies are produced and they'll go and bind on the what? On the neuromuscular junction type of receptor, which is what? Nicotinic receptors. So these are what we call nicotinic receptors. Okay, these are what we call nicotinic receptors. Okay, these are what we call nicotinic receptors. And we are saying due to some certain reason or genetic factors, then this person is producing what? Autoantibodies. So this person is producing what? These antibodies, autoantibodies that will bind on the what? These nicotinic what? Receptors. If these bind on the nicotinic receptor, what do you think? If acetylcholine is what? Produced like that, this is acetylcholine. If acetylcholine is produced, it's not going to bind on the what? These nicotinic receptors. What's going to happen now if this acetylcholine is not binding on these nicotinic receptors? There will be what? Weakness. There will be no contraction. So here there will be decrease in the what? Contraction. So if there's decrease in the contraction, what do you think? This is what? Weakness. So basically, people with myasthenia gravis, basically they have what? Muscle weakness. Okay. So now, what are the drugs that are going to be used to treat myasthenia gravis? What is that? What are those drugs? So basically there are 3 important drugs that you are going to utilize when it comes to what? Treatment diagnosis of what? Myasthenia gravis. They are basically these indirect what? Agonists. So the first one is what? Hydrophonium. Okay, so let's talk about the first one. So the first one is what? Hydrophonium. So hydrophonium is not used to treat myasthenia gravis, but it is used in the what? Diagnostic test of what? Myasthenia gravis. So we used to diagnose what? Myasthenia when it comes to what? Hydrophonium. Because what's the main reason why they use hydrophonium as a diagnostic what? Drug? Because it is what? Short acting. Maybe just less than a minute, or maybe 1 to 2 minutes. Okay, that's the duration of action of hydrophonium. Okay, you are going to diagnose. So I'll show you on how you can diagnose it using hydrophonium myasthenia gravis. Okay, using what we call Tension test. Okay, so this is the first drug that we use. Now there is also another one, neostigmine and predostigmine. So predostigmine and rivastigmine, predostigmine and neostigmine, these are the important drugs that are used what? Like at least in the treatment of what? Myasthenia gravis. But if you look at neostigmine and predostigmine, so for neostigmine, it is used to what? Relieve acute symptoms. When someone is developing symptoms acutely, they are going to use what? Neostigmine. The reason why, because the duration of action for neostigmine is about what? 30 to 60 minutes. Okay, so it's short acting like that compared to what? Predostigmine. Predostigmine, basically the duration of action is about 3 to 6 hours. So no one is used in the chronic cases of what? Myasthenia gravis. So this one we are saying predostigmine is used in the what? Chronic what? Cases. Okay, so let me just say chronic. Let me use this blue marker. Chronic. Okay, chronic, then this is basically for acute symptomatic relief. Okay, for acute, then that is for chronic. Why? Because this one is 3 to 6 hours, but this is 30 to 60 minutes. Okay, less than 1 hour. Okay, Now, there's a situation that you need to understand. Okay, since we know the drug that you can give in myasthenia gravis, because if you give this, they are going to what inhibit this acetylcholine esterase and increase what the levels of acetylcholine in the what on the synaptic gap, so that it can now, if these acetylcholine, they are a lot here, okay, they are a lot. They are a lot like that. Then they can displace these autoantibodies from this ligand gated type of nicotinic receptors. So if you remove that now, you're going to promote what increase in contraction. Okay. Now, since you are doing that, now let's say someone is taking maybe pyridostigmine, or they are taking neostigmine, but they come with what muscle weakness. There is a scenario which can come. Okay. Someone is taking pyridostigmine or neostigmine for what? For myasthenia gravis, okay? Then they come and tell you to say, okay, doc, I'm still feeling what? Weak. Although I'm taking my medication, but I'm still feeling weak. So as a doctor, you need to think in two ways. Is this person having myasthenia crisis? Basically, if you say myasthenia crisis, the disease is worse. I need to increase the dosage. Or the patient is what just experiencing cholinergic crisis, basically the side effect of what the drug that the person is getting. Because those same drugs, they can make sure that they can promote what further muscle weakness. What am I saying? So if that person comes in like that, you need to differentiate what is this, what myasthenia crisis, or is this what cholinergic crisis. You need to differentiate like that. Okay, how can you differentiate that? First of all, you need to give them what hydrophonium, so that you can differentiate between the two. Cholinergic crisis because of the side effect, the drug that you're giving. Myasthenia crisis is because of what the disease is now worsening. Okay, so what can you do? You give them what hydrophonium. If you give them hydrophonium, if now they become like, let's say if they become like, okay, there's the improvement in the what muscle weakness, basically you're going to say, okay, it's myasthenia crisis. So what am I saying? If you give hydrophonium and you observe what improvement, then basically it will tell you that this is a myasthenia crisis. Basically the antibodies, they are erode, so that is the drug that I'm giving, they are not what displacing the autoantibodies on the nicotinic receptor. So what are you supposed to do? You are going to increase the dosage of pyridostigmine and neostigmine, either the drug that you are using, okay, in myasthenia crisis. Cholinergic crisis basically is because of the neostigmine or pyridostigmine, you are giving it in overdose. So that's the reason why someone is having what weakness. But how can you know? If you give hydrophonium again, but you don't see improvement, you see the muscle weakness is worsening, then you are going to say what? You are going to see that is a cholinergic crisis. You are saying worsening. Okay, worsening, basically that is what cholinergic crisis. What do you do now? You reduce the dosage that you are giving. You are giving them neostigmine, pyridostigmine, reduce the dose. Okay. Yeah, so that's the main thing about that. And make sure that you remember, you shouldn't give what physostigmine. This one, don't give physostigmine on the what when someone having what myasthenia gravis because of what CNS toxicity. Don't give physostigmine. It's a very, very dangerous drug. This one, physostigmine, don't give it. Don't give physostigmine in what myasthenia gravis. Okay, boom. Let's go to another one. B, another clinical feature. So there's another one, post-operative areas. So basically after an operation, there is decreased motility, there's decreased GI motility, okay, due to maybe some operation that was done. What type of a drug can you give? Okay, postpartum urinary retention, basically the detressor muscles from the bladder, they are not contracting to release to remove what urine from the bladder, okay. And diabetes mellitus. Maybe someone is having, due to diabetes mellitus, they have what gastroparesis. Basically, there is paralysis of what GI muscles. Basically, there is what decreasing the motility. So whatever the case here, what we're talking about, the major thing that we're talking about is what decreasing what motility, GI motility. Okay, so decrease in GI motility. So let's just say motility. So what drug is going to increase what? GI motility or motility. What is that? We call it what? Bethanical. So this one. So here now we can use what? A direct agonist. So here we can give what? Bethanical to increase that. Okay, bethanical is used to increase the motility either in postoperative areas or postpartum urinary retention. So postpartum urinary retention, the urine is coming out after what? After delivery of the baby in females and the diabetes mellitus. So we give what? Bethanical. Glaucoma, okay. So glaucoma, there is narrow angle glaucoma and what? Open angle what? Open angle glaucoma. Okay. So for glaucoma, we can use so glaucoma basically is basically that is a disease that's going to affect the what? The eyes, whereby say basically it's a degenerative disease that's going to what? Affect the eyes, leading to what? Blindness. Okay, there are two types of open angle glaucoma and what close angle glaucoma. Okay, so open angle or and close angle glaucoma, narrow angle glaucoma. Now, what are the drugs that are going to make sure that you don't have glaucoma or glaucoma there, on the eyes? What is that drug? So we call it what? Pilocarpine. So this one, again, the direct agonist, pilocarpine. Okay, pilocarpine. But again, if you look at sulfate, it was used, but for now it's not used because it's a dangerous drug. Okay, it was used, this one. Okay, and the other one is predostigmine. Okay, you can also use it, but now the only preferred drug for glaucoma is what? Pilocarpine. Make sure that you know that. Okay, now let's come here. Okay, let's come here. It's a lot. So overdose of what? And cholinergic what? Agonist. So overdose of anticholinergic agonist. So there are some drugs that we are going to talk about, the antagonists to all these receptors that we talked about, the M1, M2, M3, M4, M5. So the antagonists. So now, what about if you have those antagonists that were antagonizing this type of receptors, but they are in overdose? So we can use cholinergic agonists to counteract what? Those antagonists, okay, from the cholinergic system. So good example of those antagonists are what? Atropine, okay, scopolamine. So we'll talk about that. Atropine, scopolamine, a lot of them, TCAs, tricyclic antidepressant drugs. So we'll talk about them, okay. So what are we saying? So if you have overdose of what is TCA, tricyclic antidepressant drugs, psychotic drugs, and also maybe if you have atropine, okay, if you have atropine, then what else? Scopolamine, okay, whatever the case, scopolamine, okay. What antidote can you give if you have toxicity of this? So the antidote that you can give for this one is what? What is that? We give what? Physostigmine. Okay, this is a very, very important drug. Now, this is when you can utilize physostigmine. Okay, physostigmine is used to physostigmine is used to what? Counteract or remove these TCAs, atropine, scopolamine from their what? From their receptors, so that now you can reverse that overdose. Apart from this, having overdose of that, also maybe if you have a blockage, a neuromuscular blockage, okay. So if maybe you block the nicotinamide neuromuscular blockers, okay, neuromuscular blockers. So remember that these nicotinic receptors, okay, not because of the myasthenia gravis, maybe you give a drug that was blocking now the neuromuscular blocker, neuromuscular junction there. If you give a drug like that, so, but you need to reverse the action. You need to have muscle contraction. You don't need muscle relaxation, because neuromuscular blockers are used in what? Maybe in what? Anesthesia. Okay, you need to relax the muscles like that. You need to give what? Neuromuscular blocker. But if you like neuromuscular blocker like what? Succinylcholine. So if you want to reverse that, What drug are you supposed to give? Now you need to give what? Neostigmine. So you need to give neostigmine. Okay? You need to give neostigmine. Okay? Whew. Let's go to Alzheimer's. What is Alzheimer's? Alzheimer's is just a disease that's going to affect the CNS, where like if you look at the CNS under Alzheimer's, there's a nucleus that we call the nucleus of Menet. Okay, the nucleus of Menet is the one that's going to be producing acetylcholine. But in Alzheimer's, that production of acetylcholine is what? Decrease, leading to what? Decrease in cognitive function, like what? Memory, learning skills, a lot of what? Like personalities, a lot of what? Behaviors that you're going to observe in the decrement of that. Okay. So Alzheimer's, now, since it's because of that, what are the drugs that are going to treat Alzheimer's? Okay, this is this is a degenerative disease that's going to affect the CNS. Okay. So in Alzheimer's, basically you are having what? Decrease in what? ACH, acetylcholine production from the CNS. Then there are some drugs that are going to increase the CNS ACH in Alzheimer's. But we are not saying these drugs, if you give them this cholinergic agonist, if you give them, they are going to treat Alzheimer's. No, they are going to just at least slow the progression of what? Alzheimer's disease. Okay. What are those drugs? Okay. The first one is what? Donepezil. Okay, the first and most important one is what? Donepezil. Okay, this is the first drug. It is an indirect agonist. Okay, what else? Also galantamine. Okay, galantamine, and the last one is what? Rivastigmine. The last one is what? Rivastigmine. Okay, these are utilized in Alzheimer's. Very, very important what drugs to take note of. Okay, then let's go to another one, Sjogren syndrome. Okay, let's go to another one, Sjogren syndrome. So this Sjogren syndrome and post-radiation. So Sjogren syndrome is what? If you remember, there are lacrimal gland and also salivary gland. So Sjogren syndrome, it has been found to say it's an autoimmune type of disorder where the salivary glands are going to be destroyed, and also the lacrimal gland are also going to be destroyed. What's going to happen to lacrimation is going to decrease. What's going to happen to salivation is going to also decrease. Okay. So now, what are the drugs that are going to, what's that drug that's going to help in Sjogren syndrome? Because that's one drug, which is what? Pirocampine. Okay, this is a very, very important drug to take note. Okay, organophosphate poisoning. Last one, organophosphate poisoning, very, very important. So organophosphate poisoning basically it happens when someone gets a drug like ecosulfate, maybe some pesticide like malathion, parathion, and also sarin gas. So what are we saying? So let's talk about it here. Okay, so these three important drugs like pesticide and also this drug, as well as what? Sarin gas. Okay, sarin gas. These are going to make sure that there is what? Organophosphate poisoning. Organophosphate poisoning, it means what? It means this enzyme which we said acetylcholine esterase is going to be inhibited irreversibly. Okay, irreversibly. So it's going to, so if you give these drugs, you are going to inhibit this acetylcholine esterase irreversibly. Basically, it means that if you inhibit it permanently, basically it's not going to perform its function in the future. We need to the body has to make new acetylcholine esterase. So these are what we call irreversible acetylcholine inhibitors. But basically, starting from hydrophonium up to galantamine, these are what? Reversible. So starting from here up to there, these are what? Reversible. But starting from echo sulfate up to sarin gas, these are what? Irreversible type of acetylcholine esterase inhibitors. So they inhibit what? This acetylcholine esterase. Okay. So now organophosphate poisoning, if this echo A phosphate inhibit this severely, but basically we put a certain range. So if it exceeds what 12 hours. After exposure, maybe to pesticide, saline gas is it's much lower. Maybe within like 3 hours, it can cause what organophosphate poison. But ecosulfate and maybe parathion malathion is within what 12 hours. Okay. So basically, what it means organophosphate poison, it means that that is esterase enzyme is going to be inhibited irreversibly, where it will start what it will undergo a process called aging. The moment the aging happens, there is no you can't do anything to that to that enzyme. You can't reverse it. Even if you give an antidote to that, nothing is going to happen because aging has already happened. So what are the antidotes? The antidote for what organophosphate poisoning? You can give them what? Atropine. Okay, atropine can just give them anytime. Okay, then there's another one. So another one is what? Prazoxime. Okay, prazoxime. Okay, prazoxime. So that is what another antidote that you can give. But this one you can give it within 12 hours, because it will go and help to stabilize this enzyme, making sure that it go back to normal. But atropine doesn't go to acetylcholine esterase. It will go to the neuromuscular junction, so that it can displace now. It's going to block those nicotinic receptors and prevent organophosphate poisoning. Now, how can you know that someone is undergoing organophosphate poisoning? You just look at this function of parasympathetic nervous system. There will be excessive salivation, excessive lacrimation, excessive urination, diarrhea, which is excessive defecation, increase in GI motility. If you excessive increase in GI motility is going to cause defecation, excessive sweating, excessive decrease in the heart rate, excessive decrease in the heart rate. It is a lot of signs and symptoms that you can see from organophosphate poison. So that's where we end from under pharmacology, under cholinergic agonists. And make sure that in the next video we are going to talk about cholinergic antagonists.